Welcome to the discussion of the Uworld question ID 3946. The patient is 40-year-old. He's male. He's not a smoker, non-alcoholic. He do no drugs. He didn't mention anything about the race. Why did he mention in particular these things, like drugs, like heroin, may cause focal segmental glomerulosclerosis as a cause of nephrotic syndrome, as we will see in the differential later on, and African Americans may develop focal segmental glomerulosclerosis. He didn't mention the race, but it might be helpful. He's complaining of fatigue, lower extremity edema or swelling, dark urine, and these symptoms started 2 weeks ago. So dark urine may be due to presence of blood, but in a microscopic level. Why is that? Because this is darker urine, but not red, not pink. It's just dark. And he might be complaining of the edema due to inability to wear the shoes or something. This is frustrating for him as well. And fatigue is a general complaint. The question mentioned the medical history. There's no serious illness, there's no drug intake, no medications are used. So, why did he mention that? Because there are some associations you need to know. Like some serious illnesses, like lymphoma, especially Hodgkin lymphoma, is related or associated with minimal change disease. Leukemia as well does. Solid cancers like lung, prostate, breast, and colon cancers are associated with membranous nephropathy. Sorry for the misspelling. Diabetes is associated with diabetic nephropathy, and so on. But these are some associations. There is no serious illness there. He didn't mention anything about hepatitis, okay? But we will speak about that later. There is no medication intake like non-steroidal, ACE inhibitors, gold, penicillamine. They all cause membranous nephropathy somewhat. So, he excluded such thing. Non-steroidals is also associated with different forms of renal diseases and different forms of nephrotic syndromes, but just keep that in mind. There is no medication intake. By examination, there is normal vitals, and there is asymmetric lower limb pitting edema. I'm expecting a generalized edema, honestly, so like around the eyes and generally over the body, but in this case it's just lower limb edema. Why is I'm expecting a generalized edema? Because of loss of protein causes decreased oncotic pressure throughout the body, so I'm expecting an edema all over the body, not like congestive heart failure where the edema is on the dependent parts, the legs, or in the lower limb. But in this case, it's just lower limb edema, and that's it. As we said before, pitting edema means it's something related to the cardiovascular rather than the lymphatic. Okay. Labs requested are like renal function tests. Creatinine is normal, and urine analysis showing proteinuria. And something not mentioned here, microhematuria. Microhematuria means non-gross hematuria. There is blood, but it's in a microscopic level. Proteinuria, 4+. Means it's more than 1000 milligram per deciliter excretion, which means there is a proteinuria, there is nephrotic syndrome characters, you have a swelling, you have edema, you have dark urine, you have proteinuria. So we think about nephrotic syndrome, how to differentiate different types of nephrotic syndrome by requesting biopsy. So biopsy is requested, it is done. The outcome of this biopsy is a dense deposits within glomerular basement membrane, and this is pathognomonic and characteristic for membranoproliferative glomerulonephritis type 2. I'm not here to discuss the pathophysiology, honestly. I'm more interested in the clinical aspects of these cases. But just to mention that it's due to C3 persistent activity. C3 is a complement, and this complement persistent activity leads to this form of the disease. The problem in this disease that there is an IgG antibodies. They are directed against C3 convertase, which is an inhibitor for C3. So C3 keeps on working, stays active, and there's a persistent activity. It's the one causing this disease. What we would do to manage this case, we already diagnosed it. We would give prednisone, cyclophosphamide, and cyclosporin to inhibit the immunity. And this is basically how we treat nephrotic syndrome. Generally, we treat nephrotic syndrome this way, and we might manage proteinuria with ACE inhibitors, and this is a general treatment. not in particular. So another thing just to note, we need to test for hepatitis, hepatitis C, hepatitis B. Why? Because there is an association between membranoproliferative glomerulonephritis and hepatitis. And if there is an infection with either of them, we treat it. Especially hepatitis C, we would treat it. So one of the things we could do is to ask about his traveling history. Did he travel elsewhere? Like, did he travel to endemic areas with hepatitis C or hepatitis B? That might be the case. Did he receive blood transfusion? These things might help. And I'm expecting to do a hepatitis test. I'm not sure if the guidelines recommend this or not, but typically there is an association between them. And we will treat them with immunosuppressants like glucocorticoids. And that concludes our discussion of this question. If you have any question, do not hesitate to leave it in the comment section. Thank you and good luck.